Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. This is your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. We're going to keep going with the heart today, and we're going to talk about the heart's electrical activity and how we interpret it. Today's episode relies pretty heavily on visual things, like an ECG. So I'm going to do the best I can to paint that picture for you with my words, but bear with me. If you can possibly, while you're listening to this episode, get an example of an ECG, a normal ECG. Google it, look it up somewhere, get an image, look in your textbook or something like that, so that you could be looking at it while you're listening to me talk about it. That would probably be helpful in terms of understanding what I'm trying to convey. In the previous episode, I talked about the autorhythmicity of cardiac muscle cells, the cardiomyocytes. And that's a really important concept to understand. So if you haven't listened to that episode, or it's been a little while since you've listened to that episode, maybe just do a re-listen, just to get a good idea of the histology of cardiac muscle cells and also their autorhythmicity, which is the way in which they generate their own electrical signals so that the heart doesn't rely upon a motor neuron to contract and then give yourself a heartbeat. The other thing it's important to know is the blood flow through the heart, which I covered in the Gross Anatomy of the Heart episodes, where we talked about blood being pumped into the arteries by ventricles, blood coming back to the heart through veins, blood going to the lungs from the right ventricle and then coming back to the heart, and then going from the left ventricle out to the systemic tissues. So that's another thing that you should probably make sure that you review before listening to this episode, but I think that you could probably get by without it. But before we get into talking about this content, I want to address a question that I received from a listener. This listener was Carla, and Carla wrote to me from Boston, Massachusetts. Carla is a nursing student in Boston, and she wanted to know about cardiomyopathy. Cardiomyopathy is a very general term, right? It's used pretty often, but it really basically means any disease that affects the heart muscle itself. And so there's a lot to talk about with cardiomyopathy because, like I said, it's a class of conditions. It's not really one condition. So it's any disorder that affects the heart muscle. And it can get in the way of the heart pumping blood the way it's supposed to. It can also disrupt the electrical signal that runs through the heart tissue so that you end up with what's called arrhythmias, which means the heartbeat is not regular. And that can really cause some problems with the heart's effectiveness in pumping blood. And cardiomyopathy is very often inherited. It is something that you get genetically from your parents and their parents, but it can also be caused by some behaviors and some other conditions. So, for example, alcohol abuse can cause cardiomyopathy. If you have long-term high blood pressure, if you already have coronary artery disease, like if you have stenosis of the coronary arteries that are supplying blood to the heart muscle, that can cause disease of the heart muscle. It can be caused by viral infections. You can have a viral infection that damages the heart muscle. And there's even medications that their side effects are cardiomyopathy. And it's not just in older people either. Like, you can get cardiomyopathy when you're young. It does tend to be something that progresses over time. So it will, if it's not treated, it will get worse. Sometimes people might require a heart transplant if it gets really bad. There are different kinds of cardiomyopathy, specifically hypertrophic, dilated, and restrictive. Those are the different kinds of cardiomyopathy. Hypertrophic cardiomyopathy is when the heart muscle thickens in the left ventricle. So the left ventricle, that's the chamber that pumps blood the furthest, right? It has to pump blood into the ascending aorta and then out to almost all the tissues of your body. When that left ventricle thickens, it can block the blood flow to the rest of the body. It can also damage the mitral valve, causing blood to regurgitate backward into the left atrium where it's not supposed to go. This is pretty rare, and in most cases, hypertrophic cardiomyopathy is the inherited kind. What you might notice is dizziness, fainting, chest pain, shortness of breath. Those are some of the symptoms of hypertrophic cardiomyopathy. And you might even notice an arrhythmia. Dilated cardiomyopathy is the most frequent kind. That's the most common thing we see. And that is when the ventricle's cavities become enlarged and stretched, and that makes the muscle weaker, and it doesn't have the ability to pump blood the way it normally would, and it also can't relax appropriately. And this can happen in adults of any age, from 20 to 60. It's more common in men, and it's been even found in children sometimes. Most people with dilated cardiomyopathy will eventually develop heart failure, where the heart no longer can pump blood. It's usually caused by chronic, heavy alcohol use, and also some of the nutritional deficiencies that are tied to alcoholism, like pernicious anemia, which is a B12 deficiency, is an example. But it can also be caused by infections or other recreational drugs, illicit drugs. It's not often inherited. This is a cardiomyopathy that is typically caused by behavior. And then the last one is restrictive cardiomyopathy. And this happens because the heart muscle becomes stiff and it can't expand, so it won't fill with blood the way it's supposed to. It's the least common type of cardiomyopathy, at least in the United States. And it usually is due to an underlying problem, some other connective tissue disorder or muscle tissue disorder that affects the actual tissue itself. This also doesn't seem to be inherited. But related to other diseases that are inherited, like scleroderma or sarcoidosis. So those are three kinds of cardiomyopathy. Thank you, Carla, for asking that question. That is a really good question. I do like the clinical side of things, and this is something that people hear about a lot with cardiomyopathy because it's such a general class of conditions, and because heart disease itself is so common around the world and is such a large factor in mortality. So I appreciate that question, Carla. Don't forget that if you have a question, please email me at minus55media@gmail.com, and I will try to respond to you via email and maybe even answer your question on an episode. Good luck, Carla, on your next exam up there in Boston. All right, so let's get into the cardiac conduction system and talk about how the action potentials that are initiated by the SA node follow a particular pathway through the heart. That is called the cardiac conduction system, and that is what makes sure that the cardiac muscle cells contract in an organized fashion to maximize the efficiency of the heart. Basically, the ventricles need to effectively pump blood in the right direction. So we want the contraction of the heart to go from the apex, which is inferior, to the base, which is superior. But we know that the electrical signals originate in the SA node, which is up top at the atria. So we need to get that electrical signal from the SA node to the apex of the heart before it starts innervating and stimulating the cardiac muscle cells to contract. So in order to get that organized contraction of cardiomyocytes so that we squeeze blood from the apex to the base, which is where the exits are, that's what we need to do. Remember that the gap junctions between cardiomyocytes allow the electrical signals to travel from cell to cell without a chemical synapse or a neuromuscular junction. That's really important. So when the SA node generates an electrical signal, the atria can contract in a wave-like pattern toward the ventricles. So we want the atria to contract first. We know that blood is passively filling the ventricles because the atrioventricular valves, which are the tricuspid valve and the mitral valve, they're open when the ventricles are resting. They're in between beats. So blood is passively coming back to the heart and filling the ventricles as it goes right through the relaxed atria. However, when the SA node generates its electrical signal, it is going to stimulate atrial contraction. And that contraction will force any remaining blood that's in the atria into the ventricles actively. But then what we want those electrical signals that are making the atria contract, we want those to get down to the apex of the heart so that it can stimulate the ventricles to contract from the bottom up, even though the atria contract from the top down. While the electrical signal eventually reaches the ventricles, it doesn't stimulate them directly because the ventricles are covered with collagen and elastic fibers called the fibrous skeleton of the heart. So the contraction of the atria doesn't jump to the ventricles at the base. So there's an insulation around those ventricles. That's the fibrous skeleton of the heart. It's not just an insulator though. It also gives structural support to the heart, holding open the entry and exit points of the ventricles and serving as an anchor for the cardiomyocytes when they do contract. At the medial base of the right atrium is another bundle of autorhythmic cells embedded in the interatrial septum. So while we have the electrical signal traveling through the atria from the SA node, they're going to reach another node, another bundle of autorhythmic cells. That bundle, which is between the atria and the ventricles, is called the atrioventricular node, and it is stimulated by the electrical signal that's made its way through the atria. Now again, instead of immediately causing the ventricles to contract, the impulse or signal travels from the AV node to a bundle of fibers called the AV bundle, atrioventricular bundle. Sometimes you'll hear people call it the bundle of His. It was named after a person. That bundle will then conduct the electrical signals down toward the interventricular septum between the two ventricles without causing any contractions of ventricular cardiomyocytes yet. The AV bundle will then split into two bilateral bundle branches, one that's going to head toward the left ventricle and one that's going to head toward the right ventricle. But first, they go all the way down toward the apex of the heart. And when they get to the apex, each bundle will go its own way, one to each ventricle. And they will give rise to smaller branches of what's called the subendocardial conducting network. You might also hear these known as Purkinje fibers. They will extend into the papillary muscles of both ventricles, left and right. The papillary muscles are then stimulated by those Purkinje fibers, causing them to contract, releasing tension on the chordae tendineae and allowing the atrioventricular valves to begin closing before the ventricles even contract. Because we don't want blood going backward from the ventricles into the atria. So the atrioventricular valves that have been open all this time, so blood can go into the ventricle, need to close when we want to pump blood out of the ventricles, because we want that blood going into the pulmonary trunk and the ascending aorta, not back in to the left and right atria. So the rest of the left and right ventricular cardiomyocytes contract almost simultaneously from the apex superiorly with a little bit of a twist, pushing the blood toward the pulmonary and aortic valves. The pressure created forces those valves, we call them the semilunar valves, to open, and blood exits the ventricles into the pulmonary trunk from the right ventricle and into the ascending aorta from the left ventricle. The pulmonary trunk will then take blood to the pulmonary arteries, the left and the right, which go to each lung. The ascending aorta becomes the aortic arch, and then the descending thoracic aorta, and it has several branches coming off of those segments going everywhere else blood needs to go. Okay, so this electrical activity means that the heart exists in two main phases: when it's contracting and when it's in between contractions. When the heart is actually contracting, that's in the middle of a heartbeat, it's called systole. And the time between contractions is called diastole. That's the time in between heartbeats when the heart's at rest. Now, the chambers of the heart don't contract simultaneously. So there's atrial systole when the atria are contracting, and then there's ventricular systole when the ventricles are contracting. The atria contract quicker. Their contraction only lasts for about 100 milliseconds, and the ventricles, their contraction lasts for about 270 milliseconds, making the total time for the heart to beat about 370 milliseconds, or you can say 0.37 seconds. A little more than a third of a second is how long it takes for the heart to actually contract. Now, since the duration of systole is fairly consistent, so under normal conditions, when your heart beats, it takes the same amount of time no matter what. So if your heart rate is 60 beats per minute versus 100 beats per minute, the really only difference is the time in between beats. So a heart that beats 100 times a minute still has about a 0.37 second heartbeat. It just has less time in between beats, which means that's less time for the heart to rest. If your heart rate is 60 beats per minute, you still probably take about 0.37 seconds to beat, but you have more time in between beats, which means more rest for the heart, which is a good thing. The heart rate is actually influenced by several factors. Biological sex, biological males and females have different heart rates. Fitness level, the more fit you are, the lower your heart rate typically is. Age, blood pressure, and genetics. And when a person lowers their resting heart rate through cardiovascular exercise, it's the time between beats that increases, making contractions of the heart less frequent. On average, a healthy adult heart beats about 75 times a minute, which comes to over 100,000 beats per day. That's a lot of work. So we know from our previous episodes that the heart muscle also has a lot of myoglobin and glycogen, because we need to make sure that we have all the oxygen and the glucose available to give us the ATP to do that 100,000 contractions per day. Now, in order to evaluate the electrical activity of the heart, we use what's called an electrocardiogram, or ECG. The original spelling was in German, so you might hear the term EKG. ECG and EKGs are the same thing. So they're just different languages. One is English, one is German. But we use an electrocardiogram, or ECG, to monitor the electrical activity of the heart so that we can make sure that the heart is conducting its signal normally and that the heartbeat is in the normal rhythm and is as efficient as it can be. So let's take some time to talk about what an ECG is and how to interpret it. This is the point in time where, if you're listening and you have the ability to do so, get a picture of an ECG, of a normal ECG, so that you can follow along with me, because again, I'm going to try to paint this picture, but it might be a lot easier if you can actually see it while I'm talking. In order to capture the electrical activity of the heart in an ECG, we have to place several electrodes on the body in very specific locations. These electrodes respond to the depolarization and repolarization of the myocardiocytes of the heart. Since the ECG can identify signs of abnormal activity from the heart, it's a really good non-invasive diagnostic tool that is commonly used by cardiologists or heart doctors. The electrodes are wired to a recording device that marks changes in electrical activity onto moving graph paper. Now that's old school. Now it's mostly computers. So we hook the leads up to a computer, and then the computer shows the electrical activity of the heart. Depending on how many electrodes you use and where on the body you place them, ECG tests typically produce 1, 3, 6, or even 12 leads. And the tracing shows a series of deflections called waves, and the flatline spaces between them called segments. So every time you see a line go up or down on an ECG, that's called a wave. And anytime you see a flat line between the waves, that's called a segment. And the actual strip with the waves and segments on it is called a tracing. Now, when you have a tracing that includes at least one wave and one segment, we call that an interval. So a region of the tracing that has at least a wave and a segment is called an interval. So it's basically a time period. We're going to spend our time on a normal single lead ECG that uses 3 electrodes. And that's going to be the best way to analyze a normal ECG. The positive electrode is placed on the left wrist, and the negative electrode is placed on the right wrist, and we put a ground on the left ankle. This configuration is known as Einthoven's triangle. The lead we are analyzing is known as lead 1 and is collected from the positive and negative electrodes in the wrists. So let's look at the waves of lead 1 first. So a baseline segment, just a flat line, represents no activity. And then what you'll notice is the first deflection or first wave is a fairly round and low amplitude or short wave. And that's called the P wave. The P wave is caused by the depolarization of the left and right atria. So we know that the atria contract first. So when there's a depolarization of those myocardiocytes, that is signified by the P wave, the first wave. The second deflection is much larger and combines 3 different waves that go below and above the baseline. And we call this the QRS complex. The first deflection is the Q, that goes below the baseline a little bit. And then we have a big spike going up above the baseline. That's kind of pointy. That's the R. And then it comes back down below the baseline a little bit again. That's the S. And we call those things the QRS complex. 3 waves, the Q wave, the R wave, the S wave. Combined, the QRS complex. And that is caused by the depolarization of the left and right ventricles. Now, at the same time that the left and right ventricles are contracting, we know the atria are repolarizing, right? So they're going into their refractory period. But that's overshadowed by the much more powerful ventricular activity. The final deflection we see after the QRS complex is another little round wave, And that's called the T wave, and that is the wave caused by ventricular repolarization. So let's talk about the intervals and the segments. The time between the beginning of the P wave and the beginning of the QRS complex is called the PR interval. And this is the time it takes for the action potentials to travel from the SA node all the way down to the Purkinje fibers of the subendocardial conducting network that stimulate the ventricular contraction. The PQ segment represents the time it takes for the electrical signal to get through the AV node. So the distance between the P wave and the Q wave, that's the time it takes for the electrical signal to get through the AV node. The RR interval from one R wave to the next R wave is the time between two consecutive ventricular contractions. And that's basically the time between one heartbeat and the next heartbeat. The flat line that goes from the end of the S wave to the beginning of the T wave is called the ST segment. And that indicates the time between ventricular depolarization and ventricular repolarization. The QT interval between the Q wave and the T wave marks the time from the beginning of ventricle depolarization all the way to the end of ventricular repolarization. And finally, the TP segment is the time of electrical activity in between beats, which should be totally flat baseline. Now, the tracing that we produce from an ECG travels at a very specific rate, and we can use this rate to calculate how many times the heart beats per minute, how long each phase of the contraction takes, and how long in between phases. Each 1 millimeter box on the graph paper or computer image that is generated represents 0.04 seconds. So if we count the number of boxes in the RR interval, the distance between the one heartbeat and the next heartbeat, and we multiply that number by 0.04 seconds, we can see how far apart the ventricular contractions are in time. So let's say, for example, there were 20 boxes in the RR interval. We multiply 20 by 0.04, we can see that those contractions are 0.8 seconds apart. So if we had several of these to look at, and they were each about 0.8 seconds apart, we'd say the heart's rhythm is regular or steady. It's a regular rhythm. Every 0.8 seconds, we have a contraction. And if we divide 0.8 into 60 seconds per minute, we can see that we get about 75 beats per minute in that heart rate. Now, also what we look at is the P waves and how they proceed each QRS complex at regular intervals. We want to see that. We want to see that before every QRS complex, there's a normal P wave. So that means that we have normal sinus rhythm. We have the sinoatrial node generating the electrical signal and that traveling through the atria first, and then going through the AV node, AV bundle branches all the way down to the apex the way they're supposed to. That's a thing we want to look for in the rhythm of the heart. We don't want elongated time in between atrial contraction and ventricular contraction. We don't want another ventricular contraction before there's another atrial contraction. We want it to all be in that order. So there are a couple of things that we might see, right? So we might see a heart rate that is over 100 beats per minute. We call that tachycardia. We might see a heart rate that's under 60 beats per minute. We call that bradycardia. Now, these things are not always abnormal. Sometimes if you're exercising, your heart's going to go over 100 beats per minute. If you are a well-trained individual, which means you do a lot of exercising, especially cardiovascular exercise, your heart rate might be below 60 beats per minute on a normal basis. That just means you're in really good shape. Now, anytime the rhythm of the heart is not the normal sinus rhythm, not coming from the SA node and making its way appropriately to the apex of the heart and back up, that's called an arrhythmia. There's lots of different kinds of arrhythmias. It's really hard to get into too much of it without having a lot of different ECGs to look at, so it's kind of tough to do in a podcast episode without any visual. So maybe you go and Google some arrhythmias and take a look at things like AV heart block, take a look at atrial fibrillation, ventricular fibrillation, supraventricular tachycardia, those kinds of things. Those are some of the common ones. Ventricular fibrillation is when the ventricles are not really contracting at all. They're just kind of quivering, which means no blood is really being pumped. And that is when they get the defibrillator out. That's the paddles that they use to shock the heart, trying to get it back into its normal rhythm, trying to use electrical signals from the outside to reset the heart rhythm so that the origination of the electrical signal is coming from the SA node again. Okay, so hopefully you were able to follow some of that ECG talk without actually seeing an ECG. Maybe you were looking at an ECG like I suggested. I hope that this helps you. I think that's pretty good for this episode. In the next episode, we're going to talk about putting it all together. The blood flow through the heart, the pressures generated by the heart that open and close the valves, the electrical activity of the heart, the sounds the heart make, which we haven't really talked about yet. We're going to put all that together, and that's another one that you might want to get yourself a visual for. So before you listen to the next episode, go to your textbook if you're taking A&P, or go to the internet and Google the Wiggers diagram, Wiggers diagram. This is a diagram that might look familiar to you when you see it. It puts all of those different things together on a chart in the same time frame so that we can see all the different activities of the heart happening simultaneously. And that is a really good way to understand what's happening in the heart. So next episode, we will cover that. All right, so thank you so much again for joining me for episode 47 of Anatomy and Physiology Bit by Bit. I really hope this is helping you get your B or better. I'm getting a lot of emails from students with either questions or just really nice comments, especially on Spotify, telling me how much this is helping them in their classes, and I'm so glad to hear that. I really do appreciate it. This is definitely a labor of love, but it is a labor for sure, which is why my episodes don't come out as regular as some people would like. It's really just about when I have the time to sit down, record, and then edit and post. So thank you so much for your patience. I really do appreciate it. I hope, again, that this is helping you out. If you have any questions, please feel free to email me at minus55media@gmail.com, and I will do my best to answer them. And please don't forget to check out Anatomy and Physiology Digital Suite from McGraw-Hill Education. This is my textbook alternative that is filled with 160 different tutor videos I've made over the years, as well as a bulleted narrative study guide to accompany that, so that you could take A&P maybe without a full 1,200-page textbook and really still understand what is going on in the human body. So I would appreciate it if you checked it out. Tell your professor about it. Tell your classmates and your professors about this podcast. That's the best way that you can say thank you to me, is to spread the word. I would really appreciate that. So anyway, good luck on your next exam. I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media. Please take the time to rate the podcast, and don't forget to check out my YouTube channel, Student Help for AP. That's Student Help, the number 4, AP. There's a whole lot of tutor videos on there that I think you're going to find helpful. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where you can find Anatomy and Physiology Digital Suite, my low-cost, tutor video-based digital learning solution for anatomy and physiology, already being used at several colleges and universities.